What up, this your boy Z. We out here making a music video out in Birmingham right now. Okay, allow the intro, fam. Okay, so I thought I'd make a video because I can kind of go through the stuff that I've done today, and hopefully it will be beneficial for you as well. They're supposed to be 10 minutes long, but I don't really care about time because I'm making a music video, so it's all good. So I'm talking about organic causes of depression, which basically means depression that's caused by some kind of other pathology within the body. So the first thing I'm going to talk about is thyroid disorders. So thyroid produces hormones, and you can have high level or low level of hormones depending on how well your thyroid is functioning or how well your brain is stimulating your thyroid to produce hormones. So low levels of thyroid hormone can mimic symptoms of depression, is what I've wrote in the bullet point. So basically what the thyroid does, or the thyroid hormone does, is it regulates your metabolism and regulates your growth, but it also affects mood. So when you have low levels of thyroid hormone, you'll feel tired like all the time. Just kind of want to get that in there. Tired all the time. Yeah. So you have fatigue, low mood, weight gain. The way to think about low thyroid hormone is everything slowing down. So you may have like constipation, and you may have like tiredness and difficulty concentrating. So if someone comes to a clinic and they've presented with tiredness and disinterest in things, and they're laying in bed all day and they're not going out and doing stuff like they normally used to, they can't concentrate, you're going to think, maybe they've got depression, especially if they've got low mood and they don't really know what's going on themselves. The point to take away from this is when someone comes to you with first symptoms of depression, so it's the first time they're presenting, to always do blood tests for other things. So the thyroid is one of them, and overproduction of thyroid hormone as well can cause symptoms. So it's not just a low thyroid hormone that can cause symptoms of depression, and overproduction can also lead to anxiety and sleeping problems, and also that's going to contribute to mood changes and can affect the quality of life. And as we know, a overproduction of thyroid hormone can cause weight loss. So fluctuations in weight, fluctuations in appetite, they should be properly investigated, because it's important to find the root of the problem and not just treat somebody who's coming in with a symptom. So we have adrenal disorders as well. So with that, you have reduced cortisol if you're talking about Addison's disease. So shout out Addison Lee, Zara's favourite tune in the world. But yeah, you have the adrenal glands which produce cortisol, which is basically steroids. And these, if you have a low level of these basically steroid producing glands, then you're going to have obviously weight loss because you're not producing the right amount of cortisol, reduced appetite, chronic fatigue again. So the symptoms can kind of mimic the typical symptoms of depression. And you'll also have irritability, and you actually will probably have depression and low mood. So these are the kind of things that you have to look out for. Cushing's syndrome, which is when you're producing too much cortisol, is actually more common in presenting with symptoms of depression. So Cushing syndrome has strong links to depression and mania. Studies that have been done show that 51 to 80% of patients that have Cushing syndrome will have major depression. So they can usually present with depressed mood, hypersensitivity, so they may be crying all the time or feeling hopeless, lack of interest. The study that I had a look at showed that memory impairment was also 83% common in people with Cushing syndrome. Changes in appetite, so that can be increase or decrease in appetite. Middle insomnia, which is where they're waking up at least once in the middle of the night. Anxiety, panic disorders are common in about 60% of these patients, and even 5 to 17% can have suicidal thoughts. The table that I have here, you can see if you can read that, but it basically shows the prevalence of depression in patients that have Cushing syndrome, and you can see it varies from 51% somewhere second from bottom, and 80%, which is second from top. So that's the variation of the studies that have been done to show how common depression is in these types of patients. So you should investigate for all these things. Obviously not you, because you're Zara and you're not a clinician, but this is what I'm going to say to the people that I'm talking to. But you should investigate for these things, and then also other investigations to consider anemia or full blood count and euthanasia. So that's just urea and electrolytes. So anemia, obviously you know that can present with tiredness, irritability, affecting your appetite. It can affect your thinking, your concentration, tiredness, chronic fatigue, tiredness. Okay, I've got to stop that. Abnormal MCV, which is basically the size of your red blood cells. So if they're really big, it usually shows that you have a vitamin B12 deficiency. So low B12 increases the size of your blood cells, whereas low iron decreases the size of your blood cells. So you can have different types of anemia. So it's important to investigate that and see if someone may be B12 deficient or folate deficient. All these things can contribute to affecting the central nervous system and can present with symptoms of depression. It's also important to go through blood calcium levels and the amount of parathyroid hormone that's being circulated around the body. So that's also to do with your thyroid. So your thyroid has 4 lobes, and in your thyroid you also have a parathyroid, and that's usually responsible for regulating your calcium blood levels. So if you have a problem with your parathyroid gland, you'll have very low levels of calcium, and hypocalcemia, which is just low calcium level, has also been shown to show symptoms of fatigue and muscle aches, and has also been known to contribute to depression. So that's also something to look out for. Vitamin D, hyponatremia, these are all things that should be investigated. Studies have also shown that assessing liver function is useful. So if you have elevated ALT levels, which is alanine transferase, that's also been known to be high in patients who have depression or patients who are on antidepressants. So liver damage can be due to alcohol, and alcohol history is also useful to kind of figure out whether someone is suffering from withdrawal, so they may be coming with withdrawal symptoms, or damage to the liver, which can also be leading to types of antidepressant type symptoms. Obviously none of these are relevant to us because we keep it halal, but we have to be aware of all the haram people around us. Chronic hepatitis is just a disease of the liver as well, inflammation of the liver, so that can also lead to increased ALT levels. So ALT is just like a marker for liver damage that we test for. Further organic causes that you should look out for are HIV, hepatitis, I've already mentioned, head trauma, encephalitis. So encephalitis is just inflammation of the brain. So post-stroke depression is also a thing. Alzheimer's, Parkinson's, any type of brain pathology is going to lead to neurological symptoms and can affect your mood and lead to depression. So these things should also be considered. And depending on what other symptoms the patient comes in with, you may or may not want to investigate further into these areas. Malignancy, if you know someone has cancer, then you know that they're probably going to have some type of depression in the way they're dealing with it. Substance abuse, withdrawal, I've already talked a little bit about alcohol, illicit drugs, etc. Opiate withdrawal, so things like codeine, morphine, people may be addicted to these types of substances, and when they don't get them for a specific period, they may present with depression. Medication or iatrogenic, so iatrogenic just means that depression that has been caused by us as clinicians. So that's medications that we give, for example. So beta blockers have been known to be linked with depression. More commonly, corticosteroids. And if you think about it, corticosteroids make sense, because if you're giving someone steroids and then they suddenly stop taking them, they're going to get very low levels of steroids, because normally the adrenal gland produces steroids. But if you're giving someone steroid treatment, you're reducing the function of your adrenal gland when you stop the treatment, because it stopped functioning for a while. So corticosteroids relates to the Cushing's and Addison's type of disease symptoms. Isotretinoin, which is one I read today. I can't remember which one it was. Is it the nicotine one? No, Varenicline is basically the nicotine patch that we have. Can't remember what isotretinoin is used for. I think it's the acne one. Yeah, it is. It's You may have heard of Accutane, raw Accutane, which is used to treat acne. That's also very highly linked to depression and increased suicide risk. So if you have acne, probably not a good idea to take Accutane, even though it still is prescribed as far as I'm aware. Varenicline is the nicotine patch or nicotine addiction type of treatment. That's also been known to cause depression. Finasteride is used for benign prostatic hyperplasia, which is relevant only to males. So they have an increase in the size of the prostate, and then you treat it with this medication called finasteride. And also hormonal contraceptives, the oral pill or the progesterone pill. Any hormonal changes caused by that can lead to imbalance in the brain and depression. So that's covering depression basically. I've already gone past 10 minutes, but I'll probably be a lot quicker when I'm actually presenting to people. Hopefully. So somatoform disorder, I've already discussed this with you earlier. So I've made a kind of case study that I saw online. So someone who's come in with abdominal pain and they've had this pain since they were a child. You've done all the relevant investigations for them, and the pain is real because she has had adhesions in the past, but it's not life-threatening. It's not something you should be anxious about. It's not something that should affect your daily quality of life, but she keeps coming in with it. So usually somatoform disorder is diagnosed by someone you see constantly. You may have a good relationship with this patient. They'll keep coming in with similar problems, and you'll investigate and there won't be anything underlying that you're worried about. So you diagnose them with somatoform disorder. So I've written here, I've already talked to you about this anyway, because I went through this with you. But yeah, that's what I was talking about earlier. So extreme anxiety about physical symptoms related to heightened bodily sensations. So you may have a sensitivity to pain, etc. So I'll skip that because I've already talked about that with you. And then postnatal depression. So I talk about epidemiology, which is 1 in 10 women actually get this. So within a year of giving birth, they'll get depression. Risk factors are family history of depression, traumatic birth. So if they suddenly had to have a C-section, emergency C-section, may have been very traumatic at the time, and that may carry on after the pregnancy and affect them. Troubled pregnancy. So if they had preeclampsia, which is I don't know how to explain everything to you in detail, but it's basically when you have in pregnancy, your placenta is not feeding your child enough, and basically hormones are released which increase your blood pressure to severely high levels, and you also get like protein in your urine, and you may even go on to get things like seizures, etc. So if you have severe types of symptoms during your pregnancy, you're more likely to get postnatal depression. Stressful life events, if you have a history of abuse within the family in the past, marriage problems, partner problems, all of these seem to have increased risk factors for this. The symptoms are basically symptoms of depression. First 2 weeks of baby blues are considered normal, so it's quite normal to be depressed the first 2 weeks. But if it goes past into a month or so, and you're starting to get persistent low mood, lack of energy or interest, concentration difficulties, may not be able to bond with your baby, you may have terrifying thoughts of harming your child, then you have to kind of go to your GP and seek some type of therapy. Obviously this is what I'm going to tell people that I'm presenting to, but the reality is that you should probably just start with self-help, increase exercise, family support, friend support. I've written down antidepressants, but obviously I don't believe in all that stuff. It can involve cognitive behavioral therapy, where you talk about it and you try and have a more positive outlook on your life, etc. But that's the basis of what I'm doing, really. And I've included a little image to kind of show the risk factors for postnatal depression. And as you can see, I'm going to end this very, very well for you, very relevantly for you. I'm just going to zoom in on on this bit right here. But yeah, anyway, I did try to keep that brief, but at the same time, I know you're not medical, so you probably don't understand some of the stuff, so I try to explain it a little bit more than I would in reality. Hope you enjoyed it, and good night.